talk, I'd like to invite Dr. Shivani Chaturvedi, who will be speaking on OCT angiography metrics correlate with glycated hemoglobin and diabetic retinopathy.
Good morning, everyone. I'll be speaking on optical coherence tomography angiography metrics correlation with glycated hemoglobin levels and diabetic retinopathy. As we all know, glycosylated hemoglobin level forms with the binding of hemoglobin and blood sugar. It reflects the average glucose levels over the past 3 months and remains unaffected by the short-term fluctuation of blood glucose levels. It's a gold standard for glycemic control, and we all know with the rise of glycated hemoglobin levels, the risk of diabetic retinopathy increases. Optical coherence tomography, angiography, is a non-invasive method and it visualizes the superficial and deep retinal plexus without dyes. It reveals the microvascular and deeper layers for better disease understanding. So the aim of our study was to sort the association between the OCTA matrices and the systemic HbA1c levels in diabetic retinopathy, and also to correlate the stages of diabetic retinopathy with the optical coherence tomography parameters reflecting the neurovascular unit. It was a tertiary care center based cross-sectional study. A total sample size was 112 and it was divided into 4 groups: controls, no diabetic retinopathy, proliferative, non-proliferative diabetic retinopathy and proliferative diabetic retinopathy, with each group having a sample size of 28. The systemic HbA1c levels were measured with the chromatographic methods, and the STOCT parameters measured were foveal avascular zone, superficial vessel density and deep vessel density. So we all can see in this box and whisker plot that is with the rising systemic HbA1c levels, the stages of it rises with the severity of the disease. Here also we can see that the foveal avascular zone is rising with the severity of the disease, whereas the vessel density is decreasing as the severity of the disease increases. On bivariate analysis, we see that the R values, there is a positive correlation with the foveal avascular zone with the rising disease severity, and there's a negative correlation with the vessel density. So in all, I would like to conclude that HbA1c shows significant association with optical coherence tomography angiography matrices in diabetic retinopathy. That is, foveal avascular zone increases with the disease severity, and the vascularity, that is superficial and deep vessel density, they decreases with the severity. OCTA detects subtle microvascular changes and it facilitates the targeted screening and monitoring of diabetic retinopathy progression. Thank you.
Do you have a data to support these findings? The number of cases which you have done and all that?
Sorry, sir. What?
Do you have a data to support all these
yes,
findings?
Yes, sir, I have. But because of the paucity of the time, I have not mentioned it here. But I have collected the data in the tabular form.
So no, but I think you just finished in 2 minutes. You should have covered all that. How many cases have you done?
So 112 sample size was taken, and there were 28 controls, 28 people in no diabetic retinopathy group, 28 in non-proliferative diabetic retinopathy, and 28 in proliferative diabetic retinopathy.
And what the biomarkers you were looking for?
Sir, basically we wanted to see, because the subtle microvascular changes are not discerned clinically. So we wanted to correlate these OCTA parameters with HbA1c levels, and we can, so that we can diagnose it earlier for better understanding, monitoring and management of the disease.
So what OCTA biomarkers were you looking at?
Sir, foveal avascular zone, superficial vessel density and deep vessel density.
But so my question is that you've anyways not taken pre-diabetics or let's say like you say a normal control if you take, or you take a disease
no
factor.
Diabetic retinopathy patients.
No, but what is the confusion in diagnosing an FAZ increase in a PDR case?
So there is no confusion, but
so then why OCTA? I mean, so if you like we have pre-perimetric changes. So if you talk about that higher HbA1c levels have certain changes on OCTA which can be discerned before clinical signs come. I don't think that if you have a group, so that is what I agree to what sir is saying. Basically, you have not shown your groups. So when you don't show your groups, So if you're saying that you're taking PDR cases, so what's the confusion in diagnosing an FAZ increase in a PDR or a decrease in, what is the cause for decrease in vision in PDR?
So the changes occurring in the neurovascular unit of the retina, the damage.
No, what are the two causes for decrease of vision in PDR? Simple. It's a very simple question, basic question. You don't need Octa for that.
Some macular changes, diabetic macular edema is the main cause, and the other factor is because of the exudation and the hemorrhages.
So
which
that's
are
all. So basically, the main cause for decrease in vision in PDR would be vitreous hemorrhage and macular changes. That's all. So there is no confusion in diagnosing that. So why do we need Octa for that? So I think if you want to really go ahead with this, I think as Sir said, I think you need data. And one is that either you compare early NPDR or mild to moderate NPDR and see whether these new Octa changes are having any significant role with HbA1c. I think this has been proven beyond doubt that blood sugar levels are correlated to the disease per se, right?
Thank you so much.
Have you followed these patients up, like when the HbA1c comes down? Are these biomarkers disappearing or something?
No, so we have not done that, but yeah, that's a very good idea.
Yeah,
go
probably
for it.
you can extend your study and come back with the results. That will be better. Thanks.
Thank you so much, sir.